And welcome back to Punchline. Tonight on Corona Watch, we focus on making sense of the numbers regarding the COVID-19 infections in Kenya. Now, the Ministry of Health almost on a daily basis gives updates on the COVID-19 cases in the country. But it is difficult to tell what these numbers really mean while testing remains relatively low. So are the government's numbers helpful at all? And what kind of sample size would be necessary to really figure out what is going on as the country battles COVID-19? Well, joining me now to discuss this is epidemiologist Dr. Mark Nanyingi. And Daktari, thank you for joining us this evening. As epidemiologists, how do you rate the Kenya government's response to the coronavirus pandemic? Are we doing well?
Thank you very much, Anne, for the question. I think the government's efforts are commendable, but I think they are still below what is expected. The numbers that we are seeing are just a tip of the iceberg. We are testing seeing about 20 or 25% of what we'd be expecting to see if the testing was ramped up. So the numbers are still very low.
Kenya has faced many epidemics before, such as malaria, for instance. What expertise and knowledge do we have from that history, and how can it be useful in a more targeted government response to COVID-19?
Yeah, in terms of the human capacity, we have very highly trained doctors and people in the medical research and things like that. So we wouldn't say that we lack the human capacity. We have core people, epidemiologists and laboratory people who are actually doing this. So I think we have the capacity in terms of the personnel that are available in the country.
All right. I want to return to your earlier point regarding our testing capabilities. So we've probably tested under 10,000 people, or 0.02% of our population. At the same time, we have almost daily briefings given by the government in terms of how many people they've tested are positive and number of deaths and so on. Based on that very small then sample size, do the figures announced by government really give us an accurate picture of how the pandemic is unfolding in Kenya?
Indeed, the numbers that have been tested by the government, there's a huge challenge in actually getting the people to be tested themselves, because they are only relying on either people who are quarantined or those people who have been, traced by being followed up, being the high-risk groups. And we know that actually there's a high percentage of people who do not show any signs, that it will be very strategic actually to target this kind of group of people to really have a representative sample of what is the really true picture of the burden of the disease in the population. So as we stand now, I think our window is very narrow in terms of the people that we are looking at, and it would be very good actually to expand. Apart from the high-risk groups, which are the healthcare workers and the frontline healthcare workers, it would be very good to try and have a random approach. But this approach also would be a little bit targeted to, I would say, a group that is prone to be highly exposed. For example, a matatu driver or a truck driver, or I would say a bank teller who is talking to people on a daily basis. I'm looking at people or housemates who come to your house, and they work and they go away and they go, where they live. So they can be actually a possibility of identifying those kind of demographics that actually focus on and try. For example, if I went to Kitengela and wrapped up a few border people, or I went to the CBD and wrapped up a few border people, then the picture would change. But if we are relying on self-reporting, whereby I have to dial the 719, I think because people fear being stigmatized, so you can't find that the numbers are going to be really low in terms of the true picture that is being tested.
All right, so it sounds to me like you're saying we do not have a true picture of where we are at all regarding COVID-19 until we can target those high-risk populations. But having said that, the Ministry of Health is rolling out what they are referring to as a mass testing. They say they'll be deploying about 12,000 kits across the country, and they'll be targeting those quote-unquote high-risk populations. First, define for us what mass testing then would actually mean in a population of nearly 50 million people.
Yeah, I think these terms are being used very figuratively, or probably I would say loosely. And when you're talking about mass testing, I mean, you're looking at a percentage coverage. You're thinking of what is the threshold that I need to cover actually to be representative enough. And by definition, or by loose translation, they might be implying that they want to cover like a huge percentage of the entire population, which is basically impractical. Mm-hmm. So I would prefer to, with a lot of caution actually, to use the word as targeted. Targeted sampling and testing. In this case, in as much as you will employ a random approach whereby you go to a population and try just to look at the high risk, it will be very impractical or economically unjustifiable actually to have an ambition of saying that, okay, we have 40 million people and for example we can test 50% of that. It's impractical. Mm-hmm. And in terms of the scientific interpretation, it wouldn't really give you any meaningful information in that kind of manner. So the sample has to be really targeted in terms of the demographics that we were talking about earlier on, and it has to be spread all over the country. So we cannot be testing Nairobi alone, and we have all these problems, all over the country. So it has the geographical coverage has to be quite representative, and the numbers have to, cover both male, female, and at the same time in terms of occupational exposure or the terms of risk of how people are going to do this. So I think the word mass testing is a hyperbole, whereby we are just trying to be ambitious, but it's really impractical. Even look at the US, look at the UK. They're all struggling with this issue of mass testing. So this is not a unique situation for us here as a country.
Right.
But I think the best thing we'll have to have a realistic approach that is scientifically justifiable, and we can infer actually the information that we are getting from those numbers to be really representative, so that when we design intervention programs or control programs, we can have confidence enough to say that we have tested a representative sample of people. So I would really support, quote unquote, the word mass.
Right.
But it's not as the way they're trying to imply it. It's not possible to do that.
All right. But let me ask you, and if you'd answer just very briefly, because it does sound on the one part, you do agree with the approach of the targeted testing, but the numbers is where the question mark is, and you agree that we probably can't even do 50% of the population. So do you have a number in mind? What for you would be a scientific approach to that targeted testing, and over what period of time until the country is able to, decide what next steps should be taken beyond the current curfew and quarantine measures that have been taken already?
You don't need really to test the entire population, but if we have a really ambition of testing even at least 1% of our population, this can be extrapolated for whatever means. 1% is quite a huge number of 40 million if you look at it in that manner. Right. So I'm talking roughly because we can test maybe 500,000 people. If we test 500,000 people, then we can have a very good argument to make on how really where the disease is. And this is just testing for active disease. Also, we understand, as you put your question, is when can we declare that probably we are safe? I think that is a long-term process whereby we need to understand the immunity that is developing in the population. And there's no way we can understand the immunity with the current testing. So the immunity, you have to use an antibody test. And this antibody test will actually help you to know the exposure, how many people actually were exposed during the pandemic. And this can be done at the tail end of this process, or even afterwards, whereby they will come to healthy people like you and me or anybody else in the community, and somehow probably be able to, to get some antibodies circulating.
Finally, Doctor,
but also maybe to clarify, there are no validated tests for antibodies. All of them are experimental, and for now, it will be really misleading for somebody to come up and say, I have a rapid test, or I have an antibody test that is going actually to tease out these people. So many of the tests are waiting approval by the FDA and other, regulatory bodies to be rolled out in the market. So currently we don't have an antibody test that is universally accepted.
All right. And very briefly, because we're absolutely out of time, I have some three quick fire questions for you. One word answers if possible, please. I'll start with this because you've talked about the antibody test and tests in general. Because you've talked about Kenya having the expertise already given the epidemics that we've dealt with. I mean, we have world-renowned KEMRI, maybe a little rundown, but nonetheless, some of the best scientists on the continent here. What is your confidence in terms of Kenya taking the lead in developing some of these things, creating our own capacity to design and develop those tests here, and to use them, that being one. And two, having said that, you said it's more of a long-run picture. So in terms of the current epidemic control that we have in the country, are we talking 6 months, 12 months? Look at the US government. They're starting with what they're calling an unlocking plan, if you like, that will be rolled out between states. And the government has set up, some very specific procedures for each state to follow. So in terms of that long-term plan for any possible path to what could be normal post-COVID-19, what does it look like for you from a science perspective? 12 months down the line? 1 year down the line? I mean, 2 years down the line?
I think it is a very good question, but this all depends on how the evolution of the disease. I think we as a medical researchers and people who are involved in scientific research in Kenya, we have been trained actually, and there are our mentors and our seniors who are really, I would say like world-class scientists. So we cannot really say that we don't have the scientists here. I think what we don't really have is the funding, the ability actually the government to incentivize medical research. And if you don't have that, and then you're going to have this brain drain of actually the top scientists actually running away and going to do groundbreaking research in other countries, probably in the UK or wherever. And the Kenya Medical Research Institute is a pioneer research institute actually in global health, and it has all this capacity in terms of human capacity. There might be challenges in terms of infrastructure or probably in terms of the kits and those things that we are talking about. But I think the human capacity is there. What we are lacking on actually is to invest in research, evidence-based research that can actually help us in policy planning.
Right. Thank you very much for speaking to us this evening, Dr. Mark Nanyingi, and do stay safe.
Thank you very much, Anne. And we also hope that we're going to flatten this curve very soon, and probably our lives go back to normal. Thank you very much.
Certainly can't wait. We're going to take another break, and we're back with more after this. Stay with us.